Elena, you can start.
Perfect, thank you. I'm just waiting people to join. I see that there are still some people joining, so I wait another 10 seconds and then we will start. Very nice. Good afternoon, everybody. Welcome to this webinar of the European Reference Kidney Network. My name is Elena Levchenko. I'm a pediatric nephrologist from Amsterdam, and I'm going to moderate this webinar today. So the webinar will be presented by Pete Schlingmann from Münster, Germany, and the topic is familial hypomagnesemia. And we have a special guest today, Susana Carvajal Arjona from Barcelona. She is a patient representative, also the mother of the child, and she will start with the introduction. But let me first introduce our first speaker, is Dr. Karl Peter Schlingmann, or Pete Schlingmann, as you know him. He is an associate professor of the Department of General Pediatrics at the University Hospital Münster. We know Pete from his very high-level publications. He has identified several new genetic defects in different forms of Bartter syndrome, renal magnesium wasting, infantile hypercalcemia. He published many papers, several book chapters, and is really an expert in the topic. And now I will give a word to Susana, who's also an expert in the topic from the different perspective, from the mother perspective and from the patient representative perspective. So she will start the webinar, but before giving her a word, I would like to remind you that your phones are muted during the webinar, but you can write your questions in the panel that you see on the right side of your screen, and these questions can be written during the whole webinar, and at the end of the session I will ask them and we will try to answer them all. So thank you all for attending, and Susana, the word is yours.
Thank you very much. So nice to see you again. So I introduce myself. My name is Susana Carvajal Arjona. I am first of all a mother, a caregiver of 13 years old child with familial hypomagnesemia, with nephrocalcinosis and hypercalciuria, without ocular involvement due to mutation in the Claudin 16 gene. My son is near to the final state of kidney disease, near kidney transplant. We are creatinine of 3 milligrams per deciliter and a glomerular filtration on the rate of 10T. We will possibly opt for the live transplant, and after certain tests, we will see if I will be his possible kidney donor. As European patient representative EPAC on ERKNet and president of the Federation of European Patient Groups affected with kidney, rare and genetic diseases, FEDERG, I know that in the description of rare kidney diseases, it is important to include unmet needs along with the clinical description of our pathologies. Hereditary hypomagnesemia are various and different, but I will try to talk only about the effects of magnesium in this introduction and focus my efforts on highlighting the importance of completing the clinical work with these needs and impacts from the patient perspective. In the case of diseases affected by the absorption of magnesium, it is necessary to know that it's not enough to have treatment, but rather to study their tolerance. Not all patients tolerate inequally all the products. Some have chronic diarrhea, and there are not studies to talk about this. Whether you are a child, young person, or adult, this chronic diarrhea consequence of taking magnesium affects your daily life for school, work, and even for love. In the same way, we must consider magnesium products and treatment adapted to the small children who do not swallow pills or whose taste makes them nauseous. And what about magnesium covered by national health system? Patient organizations have a value information and find the differences in different locations in Europe. In many places, magnesium is purchased by the patient themselves, and it is a basic treatment. On the other hand, there is not much scientific evidence about the effects suffered by people who have lived for many years with low levels of magnesium in their bodies. For example, Gittemann syndrome patients when 40 years old cannot work or support their family. Some of them continue to work with great sacrifice, but they need low-intensity work and take frequent sick leave due to fatigue or to receive magnesium supplements intravenously. These patients suffer from continuous muscle pain, joint problems, migraines, vertigos, diarrheas again, stiffness, extreme fatigue, inflammation, paresthesias, low blood pressure, etc. Family well-being and psychological help now is fashionable in one of these on the needs that are demanded not only for the patient but also for their family. A special case when you have to undergo dialysis or transplant. So in conclusion, we can go see the next slide. Yes, there are currently many unanswered questions about magnesium. What is the best formulation of magnesium for each patient? Carbonate, oxide, lactate, citrate? What does a composition work better for some patients and just the opposite for others? Why do some patients tolerate a high dose of oral magnesium and others do not? How to get the correct dose to minimize the symptoms while having few gastrointestinal effects? We need a personalized medicine for people with hypomagnesemia, which allow us to know the dose and the type of supplementation that best suits for everyone. Thank you very much for your attention.
Thank you, Susana. Should I overtake at this point?
Yes, yeah, thank you very much, Susana. I was just searching the button to unmute myself. Yes, please. Thank you so much. I think you asked very clear questions, and then the word is yours, Pete, to answer them and many other questions. So thank you very much.
Thank you, Elena. Thanks for the kind introduction and the opportunity to present this, I think, interesting topic here. Thanks, Susana, as well for your perspective of the disease and for your questions. Originally, honestly, I did not have a slide on therapy in this talk, but I now inserted one, and I hopefully can at least answer some of the questions. But before coming to the topic of therapy in the field, I will try to give you an overview of the different parts of the kidney tubule where magnesium is reabsorbed. How do these processes work? What did these different kinds of diseases tell us about the physiology of the tubule and about the pathophysiology of the disease? And to introduce you to the topic, I might present you first some of the symptoms and the development of hypomagnesemia or magnesium deficiency in a patient. And these symptoms of hypomagnesemia develop over time, so it might take a couple of days or even weeks until clinical symptoms develop and until a child or even an infant gets severely hypomagnesiemic and symptomatic. And as you can see, these symptoms, at least in the beginning, are highly unspecific, like nausea and vomiting or weakness. And later on, after a few weeks, for example, these typical symptoms like paresthesias, weakness, muscle cramps, or even seizures, cerebral seizures or arrhythmias might develop. And in the general population, there might be a lot of different etiologies for magnesium deficiency, as you can see here, like chronic disease. Diabetes is one of the most often mentioned ones, but also drug use, especially diuretics, of course, but certain antibiotics as well as immunosuppressions. And especially also the proton pump inhibitors is a group of drugs that quite frequently causes hypomagnesemia. But today, on the other hand, I will try to focus on the hereditary disorders and as one important etiology of hypomagnesemia. And I would like to start with a poll question quite right from the start. As you can see on this slide, you can see the kidney tubule, and you can see how much sodium is reabsorbed along the kidney tubule on the left side. And as you can see in the proximal tubule, there's already 2/3 of sodium chloride reabsorbed. And then the second big portion of sodium chloride is reabsorbed in the thick ascending limb. And the distal convolute on the upper right side is basically responsible for the fine-tuning of salt reabsorption, but only 5% of the sodium chloride are reabsorbed here. But do you have any idea what about the magnesium reabsorption along the tubule? Steffi, are you going to present a poll question at this point, or?
Yes, I will start it now, and then everyone has 30 to 40 seconds time. So the question is, where's the majority of filtered magnesium reabsorbed? Proximal tubule, thick ascending limb, distal convolute, or collecting duct?
Yes, does it go along with the sodium, or is it a little different? Are there parts of the nephron that are more friendly to magnesium than to sodium chloride and vice versa?
So everyone has another 10 seconds.
I'm not able at this point to see the results yet.
Let's see. Can you see it now? Otherwise, maybe Elena can, or I can also read them to you. So it's the most of the people with 39% chose thick ascending limb. Then 32% proximal tubule, 25% distal convolute, and 4% collecting duct.
Okay, thanks a lot. And I mean, I think this is not that bad at this point, but as you can see here, it's a little more different compared to sodium. So the proximal tubule reabsorption in the adult, one has to say, reabsorbs only about 15% of filtered magnesium, so much less than of the sodium. It might be more a high percentage in an infant, where the tight junctions in the proximal tubule are still a lot more leaky. But in the older human being, the vast majority of magnesium is reabsorbed in the thick ascending limb. And as in salt reabsorption, the fine-tuning of magnesium reabsorption takes place in the distal convolute. As you will see later on, a lot of these disorders affect this part of the tubule. And this is maybe even more important than in the salt reabsorption, which is not shown for sodium. Here is the aldosterone-sensitive distal nephron, but for magnesium, the distal convolute is basically the last portion of the nephron where magnesium is reabsorbed. There's no reabsorption later on, so that about 4 millimoles per day for an adult, but that equals also up to 3 to 5% of the filtered magnesium is finally excreted in the urine. So first, I would like to go into much more detail for the thick ascending limb. And I would like here to start with the physiology of magnesium reabsorption in this part of the nephron. And as you can see here, the magnesium reabsorption here takes place via the paracellular route, so not through the cell, but in between the cells. And as you can see here on the left side, you have special
interruption. I'm sorry, but your slides are not moving. I'm sorry, it's Elena. Okay. Your slides are moving. Yeah, you still have the slide with a poll. Yeah. Okay. Now it's
and as you can see on the left side here, the magnesium reabsorption takes place in between the cells through specialized tight junctions here, and these tight junctions are composed of different claudines. And to go much into detail with the claudines, I would like to present the first disease. And I think Susana already introduced this prototype of thick ascending limb disorder already. It's called familial hypomagnesemia with hypercalciuria and nephrocalcinosis. And already from the name, it becomes obvious that magnesium is wasted together with calcium, finally leading to a severe degree of nephrocalcinosis, as you can also see on the upper right side. But patients usually present, I would say, maybe already in early infancy or also at school age, with symptoms originating from the urinary tract, like polyuria, polydipsia on one hand, but especially urinary tract infections and even kidney stone disease. But the most intriguing feature of the disease finally is the development of chronic renal failure that is basically invariable. So basically all patients will develop a continuous decline in renal function over time. And an additional feature is the hyperparathyroidism that develops early and is not a consequence of the chronic renal failure, but of the continuous primary calcium wasting from the renal tubule. And I'm going to come back to the eye involvement a little later on. It's given here with about 25% of patients developing an eye involvement, but this is special for the second Claudine I'm going to mention later on. The first genetic discovery basically was made by Richard Lifton's group around the 2000 year, and they discovered mutations in Claudine 16, one of the Claudines that compose the tight junctions in the thick ascending limb. And these Claudine proteins basically have two different extracellular loops that protrude into the intracellular space, and they basically seal the intracellular space for certain ions while allowing the passage of other ions, in this case the divalent cations magnesium and calcium here. And as you can see, the mutations that have been discovered on one hand in the initial publication from Yale University, but also by our group later on, affect the first extracellular loop, basically where the electrolyte filter is located, allowing the passage of ions. And here you can see the intercellular space with two different Claudines located on both sides, and these different Claudines can even be different Claudine entities that build up the tight junctions together. And shortly after the first discovery, a few years later, basically Martin Conrad and our group basically discovered mutations in a second Claudine in the original patients that had been described in the early 1990s, mainly originating from Spain. And all these patients, or many of these patients, had a severe ocular involvement with macular coloboma, as shown on the left side, for example. And again, many of these mutations affect the first extracellular loop also of Claudine 19. So basically, mutations in Claudine 16 as well as in Claudine 19 are responsible for this disease. And if we compare these two patient groups, and this has been a bigger review study involving Rosa Vargas from Paris, as well as Gemma Ariceta from Barcelona as well. And together in collaboration with these colleagues, it was possible to compose these two big cohorts with about 250 patients. And as you can see here, basically the degree of hypomagnesemia, hypercalciuria, and nephrocalcinosis, this is basically the classic triad of the disease, but also the percentages for kidney stone disease, urinary tract infections, everything is pretty similar between the Claudine 16 group of patients and the Claudine 19 group. And also the development of chronic renal failure, as you will see a little later on. And only the ocular abnormalities are basically isolatedly present in the Claudine 19 patients, much more often. But if we compare the development of chronic renal failure, which is basically the most important aspect of the disease, then you can see here again from this big group of patients that there's not really a big difference between the two patient groups. The median age at developing end-stage kidney disease is 23 for the Claudine 16 and about 25 years for the Claudine 19 group. If we try to predict the velocity of the decline of renal function, it is important to look at the specific mutations. So there is a certain genotype-phenotype correlation in the disease, and basically we've been able to functionally express many of the mutations and to allow a classification in a partial loss of function, here is represented by the PL, and a complete loss of function like CL on the right side. And as you can see here, if there is at least one partial loss of function present in the patients, you can see that the decline is much slower than in the patients with two complete loss of function mutations in the lowest curve, where they reach end-stage renal disease before the 18th year of age. And if we compare this again for two complete loss of function mutations here, this is only shown for Claudin 19 in this case, and the others at least had one partial loss of function or unclassified ones. You can see that the complete loss of function mutations show a more severe degree of disease and reach end-stage kidney disease a lot earlier than the others. So this appears to make sense clearly. So the message from the disease is basically that the renal phenotype is indistinguishable for Claudin 16 and 19, and also the evolution of chronic kidney disease appears to be very similar, but there is a genotype-phenotype correlation, meaning that at least one mutant allele that has a partial loss of function might delay the development of chronic kidney disease, at least to some extent. So that was at least a short overview on this familial hypomagnesemia with hypercalciuria and nephrocalcinosis. In the next part of the talk, I would like to present a huge number of different disorders affecting the distal convolute, and I hope that I also have time to present some novel disorders that not everyone will be familiar with. And it really gets complex in the distal convolute, but if we look at the transport processes first, you can see that the transport of magnesium in this part of the nephron is transcellular, basically consisting of an apical uptake of magnesium into the epithelial cell, and a basolateral extrusion process that is most likely coupled to sodium here, but the molecular entity that is present on the basolateral membrane is still not completely resolved. It might be a protein of the SLC41 family that transports magnesium out of the cell in exchange to sodium ions. But there is also no disease, at least no hypomagnesemia, that is affecting this basolateral extrusion process. There are a number of additional disorders that affect salt reabsorption at the same time, and I'm not going to cover Gitelman syndrome as well as HNF1 beta nephropathy in this talk in too much detail, as I think they might be covered in other talks as well. But to give you an overview about the phenotypes in the different diseases, this is even more complex, the slide, but I tried to pick out at least two different diseases with a red box here, as some of the others affect only single families, or at least single families have been described only with some of the other entities, or the other entities might be covered somewhere else. But I think the important entities here are hypomagnesemia with secondary hypocalcemia caused by TRPM6 mutations. Basically, these affect the apical uptake of magnesium into the cell by mutations in the epithelial magnesium channel TRPM6 on one hand, and these patients present early in life, basically in infancy, with severe degree of hypomagnesemia and usually cerebral seizures, and they really have to be supplemented with magnesium in high doses for their entire life. But if they are, the clinical outcome of these patients is quite favorable. And I would like to mention a second disease indicated down here that's caused by dominant or even de novo mutations in CNNM2. And CNNM2, the role in the cell is still not completely resolved, but it might be a magnesium sensor that senses the magnesium in the interstitium here on the basolateral side, and might not be directly involved in transport of magnesium rather than in the regulation. And these patients usually present in infancy or a little later also with cerebral seizures. And they invariably develop, obviously, a certain degree of mental retardation, or at least cerebral dysfunction. They show a hypomagnesemia about 0.5 millimoles per liter usually, but they are really tough to supplement, meaning that you might improve the serum magnesium levels to a certain degree, but they usually stay hypomagnesemic, and you really have to judge if a higher supplementation makes sense in these patients for their well-being, or you have to accept a certain degree of hypomagnesemia. I believe it does not really change the clinical outcome if they stay hypomagnesemic to a certain degree. I inserted a second question here for a little poll question for those maybe at least a little familiar with the distal convolute. What is the major genetic differential diagnosis for Gitelman syndrome that is typically caused by NCCT defects or SLC12A3 mutations? Are you already able to see the poll question again?
Yes, I just started it. So everyone has another 30 seconds.
Unfortunately, I'm still not able to see the poll.
So I give another 5 seconds and then I close the poll. Then maybe Elena can.
There is a number of diseases that also show features of a Gitelman syndrome that are indicated here on the right side. But if you really suspect a Gitelman syndrome in a patient and you do not identify mutations in SLC12A3, in what gene would you try to look next? If you do not have additional extrarenal features, maybe?
Yeah, should I read it, Stephanie, or would you read it?
You can read it.
Okay, so I will just read it for you. I think most people so the majority, I don't see sharing poll results. Wait a second. So I will just read it from up to down. So KCN G10, 15%, MTTI is 1, I don't know, is 0, HNF1 beta is 26, CCNKB 56, and FIX2 4%.
Okay, so the most common answer was CLC-NKB, which is certainly correct. I mean, more than 10, maybe even 20% of Gitelman syndrome might be caused by CLC-NKB mutations, which are classically a cause of classic Bartter syndrome, but if affecting more severely the DCT, the clinical picture might be invariably or not distinguishable from classic Gitelman syndrome as well. But HNF1 beta is not completely wrong. I mean, if you have features of Gitelman syndrome in such a patient, these symptoms might develop a little later on. The hypomagnesemia, which has been nicely shown by Detlef Bockenhauer's group, develops over time. But then you might indeed have a Gitelman picture in these patients. And if you suspect HNF1 beta in a Gitelman patient, on the other hand, you might look for Charcot features also in these kinds of patients, like cystic dysplasias or urinary tract malformations. So the most favorable answer was this. So at this point, I inserted a slide on the therapy, which is usually performed via the oral route for the continuous supplementation, but might be administered IV in the beginning, which this is a picture that was originally made for TRPM6 patients, I have to admit, which are supplemented via the IV route if they are really small infants in the beginning. And this has to then be continued by oral supplementation. In the infants, you usually do this with IV solutions in the beginning, and then you switch to tablets or powder formulations. And we usually used to prefer organic compounds like citrate, aspartate, or gluconate over oxide or even carbonate, as the bioavailability and the solubility of these salts is better, and they are reabsorbed to a higher percentage than the others, which is the classic thinking about this. And so the main side effect of the supplementation, the diarrhea, might be less with organic compounds. And if you look at the dose that you usually need to supplement a patient, this also changes over time. You might really start with high doses of maybe even up to 4 millimoles per kilogram per day in such a patient. But then, as you can see here on the left side, for the entire cohort we had at that time, then you can see that you basically end up with 4 times the RDAs. So the recommended daily allowance is 0.25 millimoles per kilo per day, and you end up with a little less than 1 millimole per kilogram per day for these different compounds in these patients. And I believe that the dosages for the other disorders are not that much different. You might end up with a slightly lower dose, but as a rule, 3 to 4 times the RDA is a good target to aim at. Now I would like to switch to some new disorders that have been discovered in the last years, and I think maybe not everybody will be familiar with at this point. So if we come back to the Gitelman syndrome again, then you end up with about 10% of patients still lacking a genetic diagnosis. So there might still be genetic heterogeneity in this disease, which is classically caused by NCC defects here, impairing salt reabsorption in the distal convolute. But there might be a lot of other processes, like here, basolateral potassium recycling, for example, that also cause a Gitelman-like picture. But in these 3 families, all these common differential diagnoses had been ruled out. And here are the larger pedigrees of the initial families that we had, with a large consortium from Paris, London, and also Germany at that point. And if you see these types of pedigrees here, poll question number 3 is, what kind of inheritance pattern could you suspect?
I will start the 3rd poll. What kind of, I just wanted to say that I started the 3rd poll. What kind of inheritance pattern do you suspect? Autosomal recessive, autosomal dominant, X-linked recessive, X-linked dominant, or mitochondrial? So everyone has another 20 seconds.
Okay, I don't see a result. Oh, Stephanie. Yeah.
Can you see it now?
Right. Yes, I can see. So I will read it for you, Pete. So autosomal recessive. Yes, autosomal recessive 25%, autosomal dominant 46%, X-linked recessive 7%, X-linked dominant 11%, and mitochondrial 11%. So the majority.
Okay, that's interesting.
It's very interesting, yes.
Yeah, that's an interesting result. I mean, you can surely see affected in every generation that you can see here, and you might appreciate that there is mainly inheritance from the mother to the daughters, as well as from the mothers to the sons. So it could be X-linked dominant as well. We do not see inheritance from fathers to sons, so this might not completely exclude X-linked inheritance, but this inheritance pattern always from the mothers to their offspring, with different sexes of the offspring affected, might as well indeed be mitochondrial. So after basically excluding via exome sequencing common forms of Gitelman syndrome, basically when we saw these pedigrees, we indeed suspected maternal inheritance or mitochondrial inheritance, and basically focused on the mitochondrial genome, to be honest. And indeed, in the end, we could identify several mutations in the mitochondrial genome, and I will show you the positions later on. So there had been 3 different mutations in these 3 families in the end. And after finding or identifying the mutations in these 3 families, we screened a larger cohort of Gitelman patients, mainly from Paris, from Rosa at that point, and we were indeed able to identify identical mutations at position almost 600 and 4,000 in the mitochondrial genome in an additional 9 families. So in the end, we indeed ended up with 13 families affected by 4 different mitochondrial mutations, and these are indicated here in red and in blue as they affect 2 different positions basically in the mitochondrial genome. And if you now look at the positions in the mitochondrial genome, it's indeed positions where 2 different tRNAs are encoded. So these are not protein coding genes, but they are encoding tRNAs. And indeed, the tRNAs for phenylalanine and isoleucine, these are specialized tRNAs that are used within the mitochondrium for translation, and basically carry the amino acid on one of the termini here. And all these mutations affect highly conserved nucleotide positions within these tRNAs here. And there had been a mutation before, and this is a mutation also affecting the mitochondrial tRNA of isoleucine. This was also Richard Lifton's group in Yale that published this fantastic pedigree here, also indicating maternal inheritance. And if they looked at the clinical feature of the patients, you can see a certain degree of hypomagnesemia in the maternal offspring. They always compared the maternal offspring with a non-maternal offspring, so they had sort of an internal control within this huge family. And you can see here the certain degree of hypomagnesemia that they discovered in these patients, and accompanied by renal magnesium wasting here. But in addition to the hypomagnesemia, they also saw a certain degree of arterial hypertension as well as hypercholesterolemia. And these basically 2 features are present in what we call metabolic syndrome. So we indeed, next to the Gitelman phenotype that was present here, also indicated by the hypokalemia that was also present in these patients, indicated there might have been a certain degree of metabolic syndrome caused by a mitochondrial dysfunction in this family. And if we now look at the features that we observed in our families here, you can see that we observe also a certain degree of hypomagnesemia, mainly around 0.5, but we had severely hypomagnesic patients here with 0.1 millimoles per liter as well. We can see renal magnesium wasting, and we can also see a tendency towards hypokalemia in these patients. And also, as present in Gitelman syndrome, you can see a decreased urinary calcium excretion, so the typical hypocalciuria that is present as well as in Gitelman syndrome, and also a certain degree of metabolic alkalosis. So indeed, all the features that you would expect in Gitelman syndrome are also present. But again, one of the intriguing features that we see, at least in the 6 families with the mitochondrial tRNA for phenylalanine affected, is also the development of a decline in renal function over time, so that a significant percentage of these patients were renal insufficient at the time of the study already, and which is not true for the MTTI, so the isoleucine tRNA. And if we now looked at mitochondrial dysfunction, these experiments were done with fibroblasts from patients, and this is a typical stress test for the mitochondrium, where you basically apply certain drugs that that basically stimulate the mitochondrium to maximum function and then decouple oxidative phosphorylation. In the end, you can see that indeed there is a certain mitochondrial dysfunction present here compared to the controls that nicely show this typical picture of maximum respiration during the experiment. And if we look at the respiratory chain capacity, again, you can see that compared to controls, there is a decline in mitochondrial function in these patients as well. To reproduce basically what is the effect of a decline in mitochondrial function on NCC function, these experiments were performed that basically are a little indirect. So this is not patient-derived fibroblasts anymore, but NCC transfected HEK cells. And if you basically poison these HEK cells with cyanide, which basically deteriorates mitochondrial functions in these cells, then you can also see that the transport capacity of the NCC is severely impaired, so that indeed mitochondrial function or well-being is critical for the transport of NCC, which is basically shown here by the phosphorylation of the NCC. So the transport of NCC to the plasma membrane and then for NCC function is really critical. So we now know that in addition to MTTI, also MTTF mutations are producing a clinical picture that is reminiscent of Gitelman syndrome, but in addition, patients develop chronic renal failure. So there's another differential diagnosis for Gitelman syndrome in the DCT. But to the end of the talk, I would like to present another disorder that is really interesting, and I think we already had a number of families in the beginning when we worked on this disorder, but in the meantime, we became aware that in many European countries, there have been additional discoveries of single patients or families with the disease, so it might really be a relevant differential diagnosis, and why it is critical for the patient to discover the underlying disease and then to reevaluate the patient will be obvious in a second. The main feature that we were aware of in the beginning is indeed the hypomagnesemia, and you can see here that it's again about 0.5 millimoles per liter in most of the patients. But in addition to the hypomagnesemia, there were signs of renal salt wasting like hypokalemia and metabolic alkalosis at the same time. But interestingly as well, nephrocalcinosis in the majority of the initial patients. So we had a salt wasting phenotype and hypomagnesemia and nephrocalcinosis at the same time. And we were intrigued by this combination as shown here again. So you can see the hypomagnesemia and the salt wasting again, and the severe degree of nephrocalcinosis. And the hypomagnesemia indeed results from renal magnesium wasting. So we had some features that might have been reminiscent of Gitelman syndrome again, but the nephrocalcinosis could indeed indicate that we have also renal calcium wasting in these patients, reminiscent of different forms of Bartter syndrome or FHHNC. So we really were not aware, or were not sure which part of the nephron was indeed affected in this disease. It's more the thick ascending limb or the distal convolute was not at all clear in the beginning. But in addition to the renal phenotype, the most important feature that was really debilitating in some patients right from the beginning was a severe degree of cardiomyopathy present in the patients. There was a form of dilative cardiomyopathy, as you can see here on the right side with the enlarged cardiac cavities, and the really clinical obvious heart failure in some of the patients, and the first 3 patients indeed were heart transplanted quite early in life. So at least if you develop a critical degree of heart failure in the beginning, this might indeed invariably end up in a heart transplant early in life. So this was the unique combination, and we thought it's not the result of long-lasting hypomagnesemia, but might be an independent feature of the disease. We started with all these families, and we, under the assumption it could be a recessive disease, we did not really identify promising variants, and then we try to look at heterozygous variants. But if you do this in a single patient, you end up with about 1,000 variants that you have to look at, and it's indeed not obvious how many variants you think could be responsible for the disease. So the big advantage of having more effective family is to do a combined analysis of the exomes of these patients. And if you combine these exomes, which is pretty nicely shown by this analysis, I think, is if you combine two families, you end up with only about 10 variants in the end. And if you combine 3 or 4 families, it's really in the end only one gene that all these families shared in the beginning. And this turned out to be RACD, which we did not know at all at that point. And if we analyzed the families, we saw that the mutations that these different patients showed really affected some critical residues in ATP binding motifs in this gene, and on the other hand were identified as de novo mutations in the patients. We were able to analyze most of the parents, and usually the parents did not carry the mutation. We had one mosaic in one mother, and we had one big family with maybe a little milder mutation in the end, which was inherited in a dominant fashion in this family. But what was RACD? RACD is involved in the mTOR pathway, and it's thought to be the amino acid sensor of the pathway. So it basically senses if amino acids are present, or if the nutrient situation is positive or negative for the mTOR complex that then promotes cell growth and proliferation. And for this signal, it's critical for the complex to be aware if glucose, growth factors, or even amino acids are present. And obviously, the RACD module is the amino acid sensor of the mTOR complex. And to get a better idea what the mTOR complex and RACD especially is doing along the kidney tubule, we first performed immunostainings for RACD along the kidney tubule, and as you can see here, it nicely co-localizes with uromodulin on one hand, being a marker molecule for the thick ascending limb, as well as with the NCC, a marker molecule for the DCT. So RACD is indeed present in the thick ascending limb as well as in the distal convolute, and this is sort of the negative control. RACD is not really present in the collecting duct together with aquaporin 2. But if we looked at the functional consequences of the mutations in the gene, this might be a little complex, this slide, but if you look at the different mutations present here, and the S6 kinase basically is the readout of the activity of the mTOR pathway, and the degree of phosphorylation indicates the activity of the mTOR complex. And you can see here, compared to the wild type, the activity obviously is increased in several of these mutants, meaning that obviously the mutants that we have identified are indeed activating the mTOR complex. So basically an overactivity of the mTOR complex could be responsible for the tubulopathy and the cardiomyopathy phenotype in all patients. Interestingly, the role of mTOR along the kidney tubule was basically described before, but in this publication, basically only loss of function mutations or loss of function situations of the mTOR complex had been studied, like with mTOR inhibitors, as well as with a knockout of mTOR in the mouse model, for example. And you can see here that you also end up with some polyuria phenotype and tubulopathy phenotype maybe in general, but the effects of a gain of function basically were completely unknown, and we still do not have a final pathophysiologic idea how the increase of the mTOR activity is basically affecting salt conservation along the kidney tubule. Sorry. I think this indeed is an intriguing new disease, as there might indeed be much more patients out there affected by this disease, and as soon as you discover mutations in this gene, basically as in a patient that we took care of in our center here, She did not have known cardiac disease at that time. So if you are able to discover RACD mutations in a patient with an isolated or suspected isolated tubulopathy, it's important to examine the heart for maybe a subclinical or even clinically not obvious phenotype on first view as signs of cardiac dilatation and cardiomyopathy in these patients. And our patient, meanwhile, is on a standard heart failure medication, basically, but stable under this medication, so not in need for a heart transplant at this point. So basically, to conclude what I have shown you before, or to summarize the findings from the different disorders, I think I hopefully could show you that renal magnesium wasting primarily originates from the thick ascending limb or the distal convolute, that if we have a defect in the thick ascending limb, we have a defect in renal magnesium and calcium conservation. And most intriguingly, these patients with a classic disease, FHHNC, end up unfortunately with chronic kidney disease. On the other hand, we have certain or several defects in the DCT that might exhibit isolated magnesium wasting, but also might present with features of Gitelman syndrome. And many of the defects, I did not mention this before in too much detail, might exhibit extrarenal symptoms like deafness or epilepsy as present in East syndrome, for example, or a certain degree of mental retardation, which might result either from severe tubulopathy or severe hypomagnesemia and seizures in early life, but also might be present as an additional feature of the disease itself. And the last finding was disturbances in mTOR signaling might lead to complex renal tubulopathy affecting both the thick ascending limb and distal convolute. And the last aspect of the disease, which might be especially interesting, is do we have therapeutic options for the patients in addition to magnesium or electrolyte supplementation, like maybe the use of mTOR inhibitors as a causal treatment of the disease. So I would like to thank you for listening, and I would be happy to take questions if there are any. Thank you.
Thank you very much, Peter, for this very comprehensive presentation. It's always difficult to bring information about so many diseases, and it remains a very complicated story about magnesium reabsorption, but I think you did it wonderfully, and yeah, I learned. So while people are thinking about the questions, maybe we can start with Susana. I think, Susana, you had several questions, particularly about the treatment.
Yes.
So I think Pete, you answered some questions that you have to supplement, and you can choose different salts. Do you have a preference for one salt above the other one?
We, like I indicated, we surely have a preference for organic salts, and as these are available in Germany mainly as aspartate or citrate, I would say, sometimes gluconate, we do really prefer these preparations as we think the bioavailability is better. And I do not believe that the dosage is that much different between these types of salts. It's simply that the percentage reabsorbed might be a little bit better than in the inorganic ones. But I think, as Susana indicated, there might be patients that also tolerate oxide quite well. So it might also be an alternative to at least try it, especially if, or switch the salts if you think over time they might get intolerant to it. One key feature is if you have a patient and you are not able to reach normal magnesium values, and this is true for certain types, especially of the disorders affecting the DCT. If you're not succeeding in completely normalizing magnesium, it's important to test which doses are tolerated and then not to increase the dosage further. but even maybe go a little step back to the dose that is really well tolerated and stay with the magnesium at least at 0.6 or 0.5 to 0.6. And these patients are usually clinically doing well and not experiencing that much degree of diarrhea, I would say.
Okay, and maybe you can also comment in how many daily doses do you, or how many doses per day do you recommend to divide these magnesium preparations? Because I know that was also discussion in our clinics.
Yes. It's like with a phosphate. I mean, we know that a huge proportion of the electrolyte that is reabsorbed is basically excreted in the urine within a few hours after the application. So it's really critical to divide the daily dose into, or to divide the daily amount into several doses. And I would say I would always recommend to divide it at least in 3 doses. We have retarded preparations, but the usual supplementation taken in Germany, I would say, is a non-retarded one. And if you take these non-retarded ones, 3 or even better 4 daily doses is critical. If you take these salts that, or like soda or so, and you do it in a 1 liter bottle of water, and you take the bottle with you over day, it might even be the better solution. And the more you divide the dose, the less diarrhea you experience, I would say.
Okay, so this was very practical.
Yeah.
Susana, is it answered your question?
Yes, of course. Yes, yes.
Okay.
I completely agree.
Especially because these powder preparations usually have 300 milligrams, and it's hard to reach these amounts with tablets. So you have at least take several tablets for the same dose. So putting these doses into larger portions of water is really a good option from my point of view.
Okay, thank you so much. I think this was very practical information. Then we have now some questions from the audience. So the first question is, what is the course of UTI in FHHNC?
Yeah, I think this is not completely resolved. These patients indeed might even exhibit a certain degree of polyuria as well, and this should prevent UTIs. But I think the most common explanation would be the crystals present in the urine, or the development of infectious stones also in these patients that make these patients prone to infections and from basically recurrent infections.
Okay, so thank you for this answer. So another question again about the Claudine disease. So thank you for your excellent presentation. So there are several people writing this. This is very nice. So so since the gene dose is obviously present, is there possible that very mild variants in the Claudine genes underlie hypomagnesemia induced by drugs like proton pump inhibitors without hypomagnesemia under basic conditions?
In proton pump inhibitors, I'm not completely sure if it's completely resolved, but it might be a problem with intestinal magnesium uptake. So this might be a different issue. But there was a nice publication, I think maybe 1 or 2 years ago, on an immunologic basis of Claudine-16 disease by antibodies against Claudine-16. So there might be acquired forms of hypomagnesemia as well as of other disorders caused by antibodies against these proteins. And also in these patients, the clinical picture developed much later in life, but was pretty typical for FHHNC at the same time.
Mm-hmm.
So
Okay.
I think if you have adult patients with a typical phenotype that maybe are a lot older than expected, and the renal function was normal over a long time, you could also suspect an acquired etiology.
Yeah, I think this is very interesting. It's a very interesting thing. Another question is about this new disease, RAGD mutations. So do you expect a positive response to mTOR inhibitors in this patient? Good question.
Yes, a lot of people and a lot of clinicians are basically asking if they should try it. And we discussed this also with some colleagues more heavily involved in tubulopathies, like colleagues from Rome or Detlef. But at this point, we haven't tried this in really an organized fashion, to be honest. And we personally did not try it at all in our patients. The main reason is what could be the clinical readout of a therapy in the short term or even in the medium term. We evaluated our own patients with a cardiac MRI to be sure that we do not see a deterioration of cardiac function under therapy. As you have seen for the tubulopathy, it could be that an over inhibition of mTOR could also cause detrimental effects on the mTOR system as well. So you really have to be sure that you sort of normalize mTOR activity rather than inhibiting it. And this could be a critical issue. The other point is that there are other groups that do believe that the RAGD complex is not only important for mTOR, but also for TFAP, another axis maybe related to the mTOR pathway. And it might be even better to look at that pathway rather than to inhibit mTOR. But the more practical aspect in the end was that from our patients, we have the impressions are beyond the infancy or small infant period, are at the moment quite stable with their cardiac function under standard therapy, and we were not basically confident that we would be able to monitor therapy to see really an improvement in cardiac function at this point. We could then be able to see an improvement in tubulopathy as well. That could be the other readout. Could be an easier readout maybe for the magnesium, but honestly, we are not at that point that we structurally tried this type of therapy, to be honest. But you see some of the concerns that I have.
Yes, I hear that. Yeah, and I think you're right. So then the question is regarding these mitochondrial transport RNA mutations like MTTI or now MTTF. Why do you think they have this selective disorder in magnesium transport? Or they have other signs of mitochondrial disorder, so it's really specific for the kidney tubule?
We looked at lactate acidosis, so as a classical sign of mitochondrial dysfunction, and these patients do not have lactic acidosis, to be honest. We have seen this phenomenon also with the ATP, with the sodium potassium ATPase as well. So the kidney tubule has some features that might make it prone to dysfunction of the metabolic well-being of the cell, and that's especially true for the DCT, obviously. Either a dysfunction of the mitochondrium, but also of the ATPase might interfere with transport quite rapidly. So I think it's basically the kidney tubule is the most vulnerable tissue at this point, I would say. And these mutations we discovered are basically different from other types of mitochondrial mutations in the sense that they could be milder ones in the end, which might sound now a little paradoxic, but as you can see on earlier slides, in contrast to other mitochondrial mutations here that we discovered earlier, or that are common, you can still see my slides?
Yes.
Yes, you can see in these families, you can see the degree of heteroplasmy in the patients indicated here. And you can see that the mutations are basically present in almost 100% of mitochondria of the patients. And this is rarely the case for classic mitochondriopathies. In these types of disease, it's usually the case that heteroplasmy reaches 50–60%, and the patients then get severely ill, or basically a higher percentage of diseased mitochondria are not compatible with life anymore. And in this type of mutations, it's obviously the case that you even need a very high percentage of affected mitochondria to develop disease. So we seem to look at a different type of mitochondrial disorder, maybe a sort of a milder one, which then interferes with energy metabolism, especially in the kidney tubule. That would be my idea for this.
Okay, thank you very much. And I think the last question, then we will have to stop because it's already over 5. So actually, it's a question about the Gitelman syndrome. You didn't discuss it, but the question is about their clinical differences in the presentation, that some patients have the diagnosis only late in life, while others have very severe presentation. Do you have an explanation for these differences?
Yeah, we still do not have a good explanation for this, to be honest. Even this variability is even present within single families. I mean, this has been published, I think, more than 20 years ago, that with a very similar genetic background, even the clinical course might be significantly different from one patient to the other. And the second finding is that the well-being of a person is not correlated with the degree of hypomagnesemia, for example, or hypokalemia. So you have some patients which remain severely hypomagnesemic or hypokalemic and are doing quite well, or even clinically not affected, obviously, and there are others that are supplemented quite well and the doctor is happy and the patient is not happy at all. And it's really hard to tell what the underlying reason for this phenomenon is, and we still don't know.
Okay.
Unfortunately.
Okay, that's good to see that. That there is still a lot of space research. So people who are interested in magnesium research, I think they still have a lot of space to do new discoveries, I would say. Okay, I think we can close here. Maybe you can show your last slide. I think it's the invitation for the next ERKNet webinar. And I think it was a webinar on the distal RTA, if I don't, yes. So renal tubular acidosis will be on the 9th of July. And then we have the webinar on the hereditary leiomyomatosis and renal cell carcinoma. So please register to this webinar, and those who still have to go to vacation, a good vacation, and see you next time. Bye-bye, and thanks a lot, Susana and Pete. Bye-bye, everybody. Thank you for attending.
Bye-bye.
Thank you, Elena.
Bye.
Bye-bye.
Bye, Susana.
Bye.